Hello everyone, today is our third webinar. I'm going to talk about superficial femoral artery disease and more broadly about peripheral vascular disease. This condition is fairly commonly encountered in our society and results usually in symptomatic patients complaining about intermittent claudication or critical limb ischemia. Peripheral vascular disease is a condition which affects peripheral arteries, and as a result it can lead towards symptoms and in more extreme circumstances towards limb loss, which can even be sometimes life-threatening. The manifestation of symptomatic and systemic atherosclerosis is presence of vessels which are affected by high load of atherosclerotic plaque, and as a result there is a significant reduction in lumen. Therefore the flow through that lumen is significantly reduced and has impact on organs which are supplied by those arteries. As a result of minimized oxygen supply to the muscles, in peripheral vascular disease, the most common symptom is intermittent claudication, which, if significantly reduced and progressive, can lead towards development of critical limb ischemia, resulting in significant damage to the soft tissues and tissue loss and even limb loss. As a result, advanced peripheral vascular disease can develop into critical limb ischemia and therefore presence of foot ulceration and peripheral gangrene. The most commonly affected segments of the arteries are iliofemoral segment and femoral popliteal segment. In patients with history of diabetes, as well as patients with a history of chronic renal impairment, and early patients, particularly in 8th and 9th decades of life, it is not uncommon to see symptomatic tibial distribution of peripheral vascular disease. The major risk factors which are modifiable include history of diabetes and smoking, and also history of hypertension, high cholesterol, lack of physical activity, obesity, unhealthy diet, chronic renal impairment. All of these conditions can also contribute to development and progression of peripheral vascular disease. The risk factors which are non-modifiable include age, gender. We know well that peripheral vascular disease is more common in men than women, and finally family history and genetic predisposition. There is no doubt that prevalence of peripheral vascular disease is growing worldwide, and over the last decade or so it has increased significantly by more than 20% around the world, and this includes countries with the low income or high income societies. Severity of peripheral vascular disease can be divided into three main groups. Majority of patients will fall into the asymptomatic group. Approximately 20 to 50% of patients will belong to that group. Initial presentation with the symptomatic patients is usually with intermittent claudication, which can be divided into mild, moderate, and severe, with moderate and severe more likely to affect patient lifestyle and sometimes significantly impact on ability to perform their work. The typical claudication will affect up to 30% of those patients, whereas atypical leg pain or leg symptoms may affect up to 50% of those patients presenting with suspicion of claudication. Finally, the most advanced clinical group and those who perform the worst are patients affected by critical limb ischemia. They will present with either ischemic arrest pain, minor tissue loss, or severe tissue loss, including ischemic ulcers and frank gangrene, and approximately 1 to 2% of patients presenting with peripheral vascular disease will belong to that unfortunate group. Over the 5-year period upon initial presentation, the patients will usually progress either into developed significant complications related to peripheral vascular disease, and critical limb ischemia, and that group of patients will be probably between 1 and 2%. To those who will have a worsening claudication with deterioration of symptoms and reduction of distance, and this will probably be between 10 or 20% of patients. And finally, the majority of patients, so 70 to 80% of patients, if the underlying risk factors are appropriately managed, should continue to suffer from the same amount of claudication. There will be a significant number of patients who will develop non-fatal cardiovascular complications, including acute myocardial infarctions and strokes. Over that period of time, approximately 15 to 30% of patients will die due to a number of causes. From the cardiovascular point of view, again, the main contributors will be infarctions and strokes. The fate in those patients who are affected by critical limb ischemia is not very favorable at all. Those patients have very poor prognosis from the point of view of limb loss and loss of life. Unfortunately, although this is a small group of people, they don't do well. Therefore, it is fair to say that those patients require urgent referral and treatment, as medical management is usually resulting in poor outcomes. These patients have a high risk of primary amputation, and revascularization is the only option to save the limb and their life. From that slide, it's clearly visible that endovascular treatment is a predominant treatment in terms of managing peripheral vascular disease, and it's increasing due to improving technology, improving results, and particularly due to the fact that this treatment is involving minimally invasive techniques with small amount of complications, good results, and rapid recovery, which is important for those patients. In terms of options of treatment, they include number of interventions, balloon angioplasties, drug-coated balloon angioplasties, stenting, atherectomies involving iliac segment, infrapopliteal segment, femoral popliteal segment. Depending on the location, certain aspects of treatment are more favorable than others, as demonstrated by this graph. It is quite important to realize that the results of angioplasties have improved significantly, and the results of stenting have also improved, and this is due to drug-eluting technology, which has been implemented in both balloon angioplasties and stenting. This improves patient outcomes by reducing significantly rate of wrist stenosis. The wrist stenosis is the main complication that is affecting endovascular interventions. It has been fairly high in the past. It has improved significantly over the last decade or so, particularly after introduction of drug elution technology. There is a number of those stents available these days, and clearly the impact of this medication is quite significant, particularly over the first 12 to 24 months, where rate of fibromuscular dysplasia responsible for stenosis has been significantly reduced due to elution of medication from the surface of the stent or from the surface of the balloon during angioplasty. To finish that presentation, I will show a few slides which deal with the typical patients presenting with the significant lifestyle limiting claudication resulting from chronic occlusion of the entire length of the left superficial femoral artery. This slide represents access to the artery, which is obtained under local anesthetic with the ultrasound guidance. The profunda femoris artery is well represented here with multiple collaterals. The superficial femoral artery is occluded with a short stump. These are collaterals of the profunda femoris artery, which are then reconstructing above knee segment of popliteal artery visible in the lower part of that photograph. After recanalization, which is subintimal, the artery is predilated with the balloon and new lumen is created, and this picture shows clearly flow through the recanalized, previously chronically occluded superficial femoral artery. There will be multiple areas of dissection and stenosis visible initially, and those are then treated with utilization of appropriate stents. Usually there will be drug-eluting stents or drug-eluting angioplasty balloons, depending on the circumstances and severity of dissection. This is a typical picture of subintimal recanalization with a spiral new lumen of the superficial femoral artery, and measurements are taken to establish the size of the balloons and stents required. This is the proximal segment of the left superficial femoral artery following stenting utilizing drug-eluting stent with the appropriate appearance and preservation of the profunda femoris artery. Finally, distal segment of the superficial femoral artery and flow through the popliteal artery at its transition between the superficial femoral artery at the adductor canal. The results of endovascular treatment of peripheral vascular disease are encouraging and continuously improving. This is an appropriate way of treating those patients. Patients with intermittent claudication should be managed medically, but if that claudication is deteriorating or impacting on the lifestyle, the endovascular treatment should be offered. Patients presented with critical limb ischemia should be referred rapidly for treatment as they face high risk of limb loss and significant risk of life loss. Conditions treated by endovascular means have enhanced enormously over the last couple of decades due to improved technology, and currently we can treat those patients practically at all levels, including aorta, iliac vessels, femoral popliteal segment, as well as tibial vessels. Once again, thank you very much for your attention, and I'll invite you for our future seminars.